Hello again, my name is Taylor Ryder. I'm here to present my case connections for Unit 4. I did choose to do both Case 1 and Case 2 of our series, and we will discuss them here. For Case 1, we are presented with a newborn girl who appears normal following birth. However, 24 hours later, she develops several symptoms, including lethargy, hypothermia, and apnea. We're told that we're suspecting a metabolic disorder, and we are ordering a panel of labs. So our first checkpoint question for this case is which diagnostic would be the best to distinguish between a urea cycle disorder and a disorder of beta oxidation? And our options are given below: A, B, C, and D. Choice A, blood glucose. This lab would be unrelated to a disorder of the urea cycle, and our concern with the disruption of beta oxidation is that the infant may not be metabolizing her stored fats for energy use. However, a blood glucose lab is not specific enough to beta oxidation for definitive diagnosis in this case. For example, say the test is performed and results demonstrate low blood glucose levels. The infant could be treated immediately and subsequent theorizations made about the cause, which could be interrupted beta oxidation, limiting substrates of the electron transport chain and gluconeogenic pathway, but it could also be defects of gluconeogenesis itself or even of glycolysis. Therefore, the low specificity of this lab eliminates it as the best diagnostic screening in this case. Skipping down to choice C, serum fatty acids, for similar reasoning to our elimination of choice A, this test is not specific enough to differentiate urea cycle and beta oxidation disorder. Serum fatty acid levels are highly subject to influence by hormonal control, and increased levels could be a result of any mechanism of excessive release of lipoactive hormones, including epinephrine, norepinephrine, and glucagon, all of which we've discussed in this course. Choice D, plasma glutamine levels. Glutamine is the non-toxic carrier of nitrogen in the body. So considering what varying results would be indicative of diagnostically, low levels of plasma glutamine would be indicative of glutamine synthetase deficiency or hyperactivity of glutaminase, whereas high levels of glutamine would be indicative of glutaminase deficiency or hyperactivity of glutamine synthetase. While these conditions may affect the urea cycle, the enzymes involved are not those of the urea cycle directly. And therefore, again, this is not the most sensitive test option provided. So returning to choice B, urinary acids, I would argue this is the most reasonable option of the four provided. This would be most specific to urea cycle disorder, as elevated levels of urine orotic acid is directly correlated to urea cycle dysfunction. Therefore, this test is most sensitive to differentiate urea cycle and beta oxidation, as high levels of orotic acid would imply a urea cycle disorder, and normal levels of orotic acid would ultimately rule this out. Moving through this case, the second checkpoint question we're provided is in this patient where orotic levels are elevated, as we were given a panel of additional statistics. List one urea cycle enzyme that is most likely deficient and one urea cycle enzyme that is least likely to be impaired. So the most likely enzyme to be deficient in this case would be ornithine carbamyl transferase. And I stole this slide directly from our lecture, but if this enzyme is deficient, as seen here, carbamyl phosphate is unable to be converted to citrulline. It therefore accumulates and is shunted to the alternative cytosolic pathway for pyrimidine synthesis. Here, the increased carbamyl phosphate creates a flux through the pyrimidine synthesis pathway, which is here, also taken from our slides. So it would be pumped through this cycle here, in which orotic acid is an intermediate, causing overproduction. For the least likely enzyme to be impaired in this case, I would argue it must be carbamyl phosphate synthetase 1, which is seen here. If this enzyme were inactive, we would not see an accumulation of carbamyl phosphate because it must be active as we're seeing is synthesizing carbonyl phosphate from carbon dioxide and ammonium ions. And that really wraps up our concerns for the case connection 1. So for our second case, we are presented with 2 infants. The first one is the one we talk about more. So we have a 4-day-old infant in our clinic. We're given lots of stats about phenylalanine levels, and we believe and suspect that there is a diagnosis of phenylketonuria. So let's first review what PKU is here. So phenylketonuria, commonly known as PKU, is characterized by increased serum concentrations of the amino acid phenylalanine, which we can see here. It is caused by mutations of the PAH gene on chromosome 12, as shown here, which provides instructions for making the enzyme phenylalanine hydroxylase, shown in this reaction here. These mutations are inherited in an autosomal recessive pattern, shown in this graphic here, and if expressed, decrease phenylalanine hydroxylase activity. So we'll knock this out. Phenylalanine hydroxylase catalyzes the conversion of phenylalanine to tyrosine. Therefore, its deficiency will result in an accumulation of phenylalanine. In the case of our infant, phenylalanine levels are elevated to 6.6 when the normal range is a mere 1 to 2, justifying the presumptive diagnosis of PKU. So the first checkpoint question in this case is asking, as a consequence of this presentation, which amino acid may become essential. And in order for an amino acid to be considered essential, it must be required in the diet due to an inability of the body to synthesize it by other means. In the case of PKU, the amino acid tyrosine would become essential, as it is no longer being synthesized by phenylalanine hydroxylase here in this case. This case connection then goes on to discuss phenylalanine dietary restriction therapy, as this was employed on our infant at 14 days of age, and she's having good response to this. So as a review, a low phenylalanine food pattern has proven to be effective in PKU management. Our infant in the present case experienced stabilization of plasma phenylalanine levels with this type of treatment. The diet is outlined in this graphic, with the foods of concern being those maintaining high protein levels, such as dairy, meat, fish, eggs, beans, and nuts. Anything, on the periphery of this bullseye would be a problem for somebody with this condition. Today, there are concerns of low protein in these diets, and so they have developed phenyl-free formulas for infants and adults to supplement protein dietary needs while maintaining the low phenylalanine levels needed for treatment in this case. Continuing through this case, our next checkpoint question was, what are the potential causes of the presentation of phenylketonuria? And as previously discussed, there is the genetic or enzymatic cause due to the PAH gene mutation and phenylalanine hydroxylase deficiency, but there's also a cofactor contribution. Phenylalanine hydroxylase requires tetrahydrobiopterin, or BH4, as a cofactor, as it is oxidized in hydroxylation reactions. If there was a BH4 deficiency, this could mimic the deficiencies in phenylalanine metabolism. However, in our present case, as the infant responded well to our phenylalanine dietary restrictions, it is more likely due to the enzymatic deficiency than the cofactor deficiency. However, this case continues in discussing this differentiation and provides us with another infant, patient B, who is also being evaluated for suspected PKU, and we perform a BH4 loading test. And it would like us to summarize the results of the test between patient A and patient B. So we're told that a BH4 loading test is the administration of a synthetic cofactor before a meal with blood analysis at 4 and 8 hours after administration to monitor phenylalanine levels. And this is the results of that test. And we can see patient A was our original infant here in blue, and patient B in the orange is the infant they add later in the case. So patient A, it is obvious that our original infant is a true case of PKU. as the BH4 loading has no direct effect on phenylalanine levels, implying this is of genetic or enzymatic origin and not due to a deficiency of our BH4. However, patient B demonstrates a significant decrease in phenylalanine levels with BH4 loading, insinuating that this is a matter of cofactor deficiency mimicking PKU and not a case of true PKU. And that wraps up my case connections for Unit 4. I hope you enjoyed the presentation and have a wonderful day.